So my name is Ramin Kholdebarin. I'm a general surgeon here in Sechelt, and I do want to thank everyone for taking the time to come and listen to this talk. I also want to thank Sechelt Foundation for giving us this opportunity to connect with members of community and our patients and having this information session. My talk focuses on the surgical treatment of skin cancer and specifically the options that are available in Sechelt. So as a general surgeon working in Sechelt, I get referrals from family doctors and other specialists for a variety of surgical conditions, and one of them is skin cancer. So from a patient perspective, when you have a skin lesion that you're worried about or a skin lesion that is changing, the first thing you do is you go see your family doctor, and they use their clinical judgment to decide whether this lesion requires a biopsy or whether it needs to be removed. At that point, some family doctors have the resources to perform biopsies and excisions in their own clinic, so they may do that themselves. Others may decide to refer you to a surgeon. When that referral is made, we're quite fortunate here in Sechelt that we can actually see people fairly quickly. My office can probably set up a consult in 1 to 2 weeks. After I see you in the office, and if we decide that we need to do a procedure, that will be done at Sechelt Hospital. And the wait time for that is usually about 1 to 4 weeks, depending on the urgency of the cases. So one of the common things that I do is to perform a biopsy to get a diagnosis. This is done at the ambulatory care unit, or the ACU, at Sechelt Hospital. I don't do any biopsies in my own clinic. I just find it's a bit cleaner if I do it in the hospital. And again, I'm very fortunate to have access to the resources at the hospital. All biopsies are done with local anesthetic. So I use a very small needle to inject the anesthetic into the skin. This is usually the most painful part of the procedure, but fortunately it's very quick. And once the skin is numb, the patient shouldn't feel any more pain. I generally do 2 types of biopsies. One is called an excisional biopsy. That's when we remove the entire lesion. We like to use an elliptical incision. So if you imagine this circle is the lesion, then we make an elliptical incision to take it out. The reason for this is if you closed a circular incision, it becomes all bunched up, and you get these things called dog ears, which essentially are skin tags at the corners, which can be very irritating. So we oftentimes use an elliptical incision to achieve a straight scar. So when this is closed, you get a straight, nice scar that's flat. These incisions are usually 3 times as long as they are wide to achieve that nice linear scar. So that's something I tell patients when I remove their lesion. They keep in mind that your scar is probably going to be 3 times as long as it is wide, or as the diameter of the lesion itself. For some other lesions, we may decide to do an incisional biopsy, just take part of it, particularly if it's a very large lesion in a cosmetically sensitive area. The most common way of doing this is to do a punch biopsy. This essentially is a cookie cutter. It's a very small circular blade that we rotate into the skin and take a punch out. And this is such a small incision that usually we can close it with 1 stitch, and there's no worry about dog ears or anything like that. When we get a diagnosis of skin cancer, what we call a malignant lesion, either from a biopsy or from a clinical diagnosis, the most common ones are non-melanoma skin cancer and melanoma, and Dr. Scally talked about this in quite a lot of detail. Non-melanoma skin cancer is actually the most common type of cancer worldwide. Fortunately, as Dr. Scally said, these cancers have a low rate of spreading in the body, what we call metastasis, and as such, they have low death rate. but they can grow very large locally and even be destructive, and in some cases they can spread, so we do like to remove them. And they're generally divided into basal cell carcinoma and squamous cell carcinoma. The other group is melanoma. This is a more aggressive type of skin cancer that can spread and metastasize and does have a higher mortality rate, unfortunately, but is not as common as non-melanoma skin cancer. Because these cancers behave differently, these tend to spread and be more aggressive, whereas these tend to be locally destructive. The surgical treatment is different. So I'll cover that differently as well. So the most common type of surgery that is done for non-melanoma skin cancer is something called wide local excision. This is the traditional way of removing these lesions. And what I do is that I remove the lesion with 4 to 5 millimeters of normal skin around it. And the goal is to achieve negative microscopic margins, which means that when they look at it under the microscope in the lab, they see that we remove the entire lesion. The only disadvantage of this technique is that it takes about 2 to 3 weeks to get the pathology report back to know if we were able to remove the whole thing. Fortunately, the positive margin rate for this technique is very low. It's about 5%. If we do get a positive margin, sometimes we have to go back and remove more. In my experience, if you stick to the 4 to 5 millimeter rule, it's very rare to get a positive peripheral margin. The area that gets a little bit tricky is the deep margin, how deep we go, because that's kind of a clinical judgment. And when I do these, I try to do a full thickness excision to get more deep margins. And actually another technique that I use is that I take shave biopsies of the deep margin. So if the deep margin is positive on the original sample, those shave biopsies give us additional wiggle room. This is the preferred and recommended technique for non-melanoma cancer of the trunk and extremity. So essentially anything that's below the head, this is the recommended technique. So this diagram, hopefully it's not too gross, just shows how we actually do this in real life. So this is this I think is a squamous cell carcinoma. So what we do is that first I define the clinical borders with the naked eye. Then I use a ruler and measure 5 millimeters away from that. And then, as I previously mentioned, we design an ellipse based on those borders. And after using local anesthetic, we remove the lesion. When we do these wide local excisions, a lot of times we end up with very wide defects. And sometimes it's not possible or not ideal to just close the skin. We have to mobilize the skin to free it up so it comes together in what we call a tension-free manner. A simple way of doing this is called an advancement flap, where we elevate the skin and dissect it off the underlying muscle so we can actually pull it to the center and close it. Tension is not very good for wound healing. If you have too much tension, you get wider scars, and if you have a lot of tension, the incision can actually fall apart. So that's one thing we do. And I always, again, counsel the patients that their incision will be longer than the original lesion to do this wide local excision. The other technique that's used for non-melanoma skin cancer is called Mohs surgery. Some people, think this is an acronym, but it was actually discovered by Dr. Mohs, who was a general surgeon. And in this technique, what they do is that when they remove the lesion, they check the margins as they're removing it using a technique called frozen section analysis. So they freeze the specimen, they stain it, and they look at it under the microscope, and they can tell right away if they were able to remove the entire lesion. So they get the margin status right away. That's the real advantage of this technique. This is mainly reserved for high-risk lesions in high-risk areas, such as around the lip, the eyes, nose, and ear, around the eyes and nose and ear. And the downside is that it's a very special technique. Frozen section analysis isn't available everywhere. And for example, in BC, you have to be referred to Vancouver, and there's long wait times. Last time I referred a patient for this, they waited 6 months, but it can be longer as well. So who do I select for wide local excision, particularly if you have someone who's got a lesion on their face? And this is where, and who do I send for Mohs surgery? Because I don't do Mohs surgery locally. As I said, you have to be referred. It's a bit of clinical judgment, but my goal is to be able to achieve negative microscopic margins, to be able to remove the whole thing and have a good, acceptable cosmetic outcome. And a lot of times that's dependent on size, location of the lesion, and also type of lesion. So if you have a large, skin cancer on the nose, this is a basal cell carcinoma. If I do a 4 to 5 millimeter margins around that, this ends up being a very big defect. So, and to close that, we have to use some kind of reconstructive technique, such as a skin flap or a skin graft. And if you're going to do that, it's really ideal to know if you got the whole thing. Because if you didn't, and you have to go back and revise it, then it's not ideal because you've done a reconstruction. So that's where I think Mohs is very helpful. But if you have a small lesion on the nose that you can remove with wide local excision, and I feel confident that we can get deep margins, then that can be done locally as well. So there is a bit of a clinical judgment. When we do wide local excisions, sometimes we end up with very large defects, and we have to use reconstructive techniques. Sometimes we use skin flaps, and these are essentially rearrangement of local skin to close these defects. And this shows a very large cancer on the scalp. The scalp is a very tricky area. If you feel your own scalp, you see that the skin is very tight. It's difficult to mobilize it, so we have to use rearrangement of skin to close a large defect. So this patient has a big cancer on their head, and this is a 4 to 5 millimeter margin around it. So the initial defect is going to be here, and then I make relaxing incisions on either side of this and actually rotate these two pieces of skin to bring it together. This is what it looks like right after. A couple of things about flaps. Probably the most important thing about these is the blood supply. You have to make sure the skin has enough blood supply to survive this process after you moved it around. So these arrows show you where the blood is coming to the flap. It's from these two small bridges of skin that haven't been cut. If these are too small, then the flaps will die, which can be a big problem. So that's really part of the art or the science of doing these flaps. And when I design these flaps, I'll also try and design them so if we do get a positive margin, which is rare, we can go back and revise it. So if you notice, the positive margins would be in here, in the middle, if it were to happen. So later on, we can actually go and take this out if we need to get negative margins. And I just want to take this opportunity to do a public service announcement. If you're a male like myself who's losing your hair, please wear a hat. It's very difficult to put sunscreen on your head. And I see a lot of scalp cancer. So personally, I keep a hat in my car, I have a hat in my house. So if I'm going out, there's no excuse. I won't forget to wear a hat. And hats do prevent UV damage. The other option for closing these big defects is a skin graft. This is where we take skin from other parts of the body and transplant them into the defect. These skin grafts don't have their own blood supply. They essentially a patch of skin. And because of that, we have to make them very thin. They're a very thin layer of skin because initially when we put this graft in, it lives on nutrients coming from the bed of the excision and also surrounding skin. So if that skin graft is too thick, then it won't survive. So they're a bit simpler to do than skin flaps because they don't require a lot of tissue mobilization or detailed attention to blood supply, but they're a bit more cosmetically noticeable. For example, in this, in this patient, you can see the skin graft is thinner, so it has a bit of a dimpling or sunken appearance, and the color doesn't always match either. Because these skin grafts don't have their own blood supply, they also take a long time to heal. But they can be useful, and they're used a lot by Mohs surgeons to cover the defects. The other disadvantage is the reason why most surgeons use them is that they know right away if they were able to get the whole lesion. If this patient had a wide local excision, and I'm assuming they had very good results, but if the margins come back positive and you have to go back and revise it, you have to take that skin graft off, and it's a lot harder to put a second one on. Oftentimes you have to do a skin flap or even just let it heal by secondary intention. So I don't use skin grafts a lot. I find I am able to close most defects with a skin flap that actually ends up having a better cosmetic outcome as well. So the other big group of skin cancers that I treat are melanomas. As Dr. Scally said, melanomas are a lot more aggressive. They tend to metastasize and spread and have a higher mortality rate, and therefore we treat them a lot more aggressively. And the standard treatment for melanoma is a wide local excision. And actually Mohs has very limited role in melanoma because we want much wider margins than just negative microscopic margins. And when we do the wide local excision, the margins of resection, or how much skin we take around the lesion, depends on the depth of invasion or how deep the melanoma goes, as shown in this diagram. So some melanomas are very superficial in their invasion, others can go very deep, and the deeper ones are more aggressive. And this information we gather from a biopsy. So if we have an abnormal lymph node, the first step, an abnormal mole or what we call nevus in medicine, and that's suspicious, the first step is always a biopsy. And it should never be a wide local excision because the margins for wide local excision depend on the results of the biopsy. When I get an abnormal mole, I try to do an excisional biopsy that is full thickness. The reason for that is because some of these melanomas, different parts of them have different levels of invasion. So if you remove the whole thing, then you know exactly how deep it goes. And you also ideally want a full thickness so you don't miss on the deeper invasion. Sometimes we do an incisional biopsy if the lesion is very large, but for the majority of these lesions, we try and do an excisional biopsy. And if you note in the excisional biopsy, we don't take any margins. We stay right on top of the lesion. The reason is, if you have a smaller scar, it's easier to do a wide local excision later. But if you take margins with the biopsy, then you end up with a bigger scar, and your final excision is going to be even that much bigger. So when we do wide local excision, as I said, the margins depend on, or how much skin we take around the melanoma. It depends on the depth of invasion. So if it's a melanoma in situ, so this is a type of melanoma that hasn't become invasive yet, so it has a 0 invasion rate, we still take 5 millimeters around the excision. If the invasion is up to 1 millimeter, so very little, it's actually 1 centimeter. And if it's greater than 1 millimeter, so everything beyond here, the margins are 2 centimeters. So we end up actually removing very large pieces of skin for sometimes even small melanomas. So, this is where the melanoma is, and this is how much skin we have to take around it, depending on the level of invasion. So it's not unusual to get scars that are like 10, 15 centimeters long to treat this melanoma. Another very important part of treating melanoma is a lymph node sampling, something we call sentinel lymph node biopsy. Again, as I said, melanomas have a tendency to spread in the body, and when they do so, they oftentimes do it through the lymphatic channels. This is a system that drains fluid from your body, but also manages your immune system that normally fights cancer. And the lymphatic channels are connected to lymph nodes. These are little glands that drain different parts of your body. And what happens is that when melanoma spreads, it tends to go to these lymph nodes first. As a matter of fact, there's one lymph node, the first lymph node that drains the melanoma, and we call that a sentinel lymph node. So when we treat melanoma, we like to remove that sentinel lymph node to know if the melanoma has started to spread. And the way we do this is that we inject a radioactive dye around the melanoma, and that radioactive dye, it's a very small dose, it's quite safe, it's not like you're exposing you to high radiation. It's a very small dose of radioactivity that we inject around it, and then this gets picked up by the lymph nodes, it gets concentrated in that lymph node. And then I use a probe to pick up the radioactive signal that's been concentrated here, and then I remove that sentinel lymph node, and we send it to the lab, and they look at it under the microscope to see if it has melanoma in it. And these are the sort of recommendations. So all melanomas greater than 0.8 millimeters deep, so not very deep, but greater than 0.8 millimeters deep, require sentinel lymph node biopsy at the time of wide local excision. We could do this in a delayed fashion, but it tends to be less accurate. So ideally, we like to do this at the same time that we're doing the wide local excision. Even thin melanomas would benefit from a sentinel lymph node biopsy if they have high-risk features such as ulceration. So these are melanomas that have a little erosion on them. So why do we do the sentinel lymph node biopsy? It's because patients who have a positive sentinel lymph node are candidates for systemic therapy. So Dr. Scally talked about these are drugs that we give patients that help kill melanoma cells. And we're getting better and better at this, and oftentimes we use targeted immunotherapy that is very specific to melanoma and also has lower side effect profile. And as I said, this is an area of active research, and we're getting better at it. I can tell you patients who have metastatic melanoma are living much longer now than they did when I was in medical school, which wasn't that long ago, it was about 10 years ago. They're also candidates for close surveillance, but this is a very important piece of information because if we don't do this, then the patient won't get that. Which can be nowadays life-saving. So I'd like to take this opportunity to thank Sunshine Coast Healthcare Auxiliary Team for helping us buy the NeoProbe. So this is the probe, this is the machine that I use to detect that radioactive signal in the sentinel lymph node and perform this procedure. And this machine is used not only in treating melanoma, but also treating breast cancer, and other types of cancer. So a very useful piece of equipment that was recently purchased thanks to the Sunshine Coast Healthcare Auxiliary Team. So how is sentinel lymph node biopsy done in Sechelt, just from a patient perspective? Unfortunately, patients do have to travel to Lions Gate the day before the procedure to get that radioactive injection. As you know, radioactive material is a controlled substance. It's only available in certain hospitals, and we don't have it available in Sechelt. So you do have to go to Lions Gate the day before to get that injection. While you're there, you also have a scan where they actually look to see where the sentinel lymph node is, so they pick up the signal using a scanner. So for example, if you've got a melanoma in your arm, they can see where the lymph node is in the armpit, which is where the lymph nodes are. The next day, the patient comes to the operating room in Sechelt Hospital. At the time of surgery, I also inject a blue dye. So this is essentially a blue color around the melanoma. And this ends up also getting concentrated in the sentinel lymph node. And I can see a blue lymph node when I'm doing my dissection. And we call this technique the dual tracer technique. One tracer is radioactive material, and the other one is the blue dye. And then the patient has the wide local excision with appropriate margins, and we do the sentinel lymph node biopsy through a separate incision. And this diagram, this picture just sort of summarizes the whole process. So this patient has a melanoma on their left chest wall. They go for radioactive injection, and this is the scan that is done. You can see there's a lot of injection around the melanoma, but there's also an uptake in a sentinel lymph node, this gland in the armpit. The patient comes to the OR the next day. I inject a blue dye around the melanoma. And then when I'm doing the dissection, I can see the blue lymph node, and I can also pick up the signal. That gets taken out, sent to the lab. They look at it under microscope to see if it has melanoma cells in it. So in summary, if you have an unusual skin lesion, you may get referred to me for a biopsy. If we get a diagnosis of skin cancer, and there's really of two main types. One is non-melanoma skin cancer, which can be treated with Mohs surgery or wide local excision locally. Melanoma is a much more aggressive type of skin cancer, and this is treated with wide local excision and sentinel lymph node biopsy. Okay, thank you very much.